Hello, this is Neil Baum from New Orleans, Louisiana. And today I have Dr. Abe Morgentaler as our guest on Grand Rounds in Urology. Abe, you are no stranger to Grand Rounds in Urology, as you have contributed many programs in your area of interest, the use of testosterone in clinical medicine. All urologists, including myself, who have been trained in the 1970s, 80s, and early 90s, heard the harangue, don't use testosterone in men, as it is like adding gasoline to a fire. You have faced many obstacles, ridicule, and even attempt at ostracism from your colleagues with your research on the use of testosterone. I have been in practice for nearly 40 years, and I have seen several game changers that have altered the care of our patients. Abe, I consider you a game changer, and your saturation theory on the use of testosterone ranks with shockwave lithotripsy, Viagra, robotic surgery, and now minimally invasive treatment for the enlarged prostate gland. Abe, you have changed the course of medicine and have spent the last 30 years educating both urologists and non-urologists on the safety and benefits of using testosterone. So Abe, let's get started. Abe, you were trained at Harvard, and I know Harvard has a very special place in your medical education. Is that where you received the idea or the genius of your research on testosterone?
Well, Neil, it's a pleasure to be with you, and thank you so much for that generous and kind introduction. I have to tell you, it's been some journey. Both exciting and challenging at different times. You know, I started with testosterone exactly as you say when I was an undergraduate at Harvard College. I've been at Harvard my entire career, college, medical school, residency, and now on faculty since 1988. And I was really going to be a biologist first. And I worked in a laboratory with lizards for 3 years. And in the laboratory, the brilliant biologist, evolutionary biologist, David Cruz, and he worked with reptiles. And so it was snakes and lizards. And I did experiments for 3 years on these lizards. And reptiles are important in evolution because they're the branch point for development of the two, what we might call higher vertebrates, which is mammals and birds. Both of them have sort of a common ancestor, which is the reptiles, and we still talk about the sort of older parts of our brain as the reptilian brain. And what happens to these little lizards is they have the sexual behavior. They've got this bright colored flap of skin that comes out when they're interested in a female. Their head bobs up and down. And if you castrate them, they don't do any of their sexual behavior because they have no testosterone. And my project was to find a way to put testosterone actually into the sexual centers in their brain. And when I was finally successful in being able to do that, their entire sexual behavior came back, even though they had undetectable levels of circulating testosterone. So what I learned, my first paper on testosterone, 1978, and what I learned from it was that testosterone was a brain hormone. When I finished my residency in 1988, and I started specializing in sexual medicine and male infertility, we had very little to offer men. Viagra wouldn't show up for another 10 years. And so because of I wondered whether these men might be like lizards. And it turned out that they were, and they responded beautifully to testosterone, which is not a surprise today. But at the time, there was almost no testosterone used because we thought it caused prostate cancer. And my career really started with that observation that, number one, that the men were like lizards in the sense that they responded, at least sexually, which was my main focus at the time. Now we know, of course, it has a lot of other things get improved with testosterone as well. But the hard part is that I believed, because I'd been taught it, that testosterone caused prostate cancer, and everyone around that I knew thought the same. And that was really the start of it all.
Well, what gave you the clue? Was that it, the lizards, that testosterone was not the culprit causing prostate cancer?
Well, lizards don't get prostate cancer. Actually, the only other animal domesticated animal that gets prostate cancer are dogs. And Charles Huggins, who won the Nobel Prize for his work beginning in the 1940s, for showing that prostate cancer was responsive to androgen deprivation. His original work came from work in dogs as well. But mine was with lizards. But the issue was that these men did so well with testosterone. Some of these men said, not only was sexual function better, but they said, "Doctor, I feel better. My wife likes me more. I wake up in the morning with optimism. I haven't done that in 10 years, 15 years." And so there was a balancing act at that point between quality of life for these men and what I still believed was the risk of prostate cancer. And the long story short is that I was nervous about these guys too, but they were willing to take a risk. And as over the course of 30 plus years, what we found is that almost everything we learned about testosterone and prostate cancer turned out to be false, with one exception, just one, really, which is that depriving prostate cancer of androgens can be beneficial. But the idea that testosterone gives prostate cancer, causes progression of prostate cancer, none of that has been borne out by the literature. In fact, it's contradicted by it.
I can imagine what a great salesman you would be if you were able in the 1980s, when you were doing your research, to convince a man to take testosterone. You were very brave to have reached out and done that.
But if I could, Neil, it's an important point. So, I really was nervous about testosterone. So I wasn't trying to convince anybody. And really the impetus for almost everything I've done has come from the patients themselves. They came to me and said, "Is there anything you can offer me?" And I would say, "Well, there's this testosterone stuff and we're worried about the risks." And the men were willing to do it. And, the most recent work that we've published that has taken it through all the different stages of being concerned about testosterone and prostate cancer, and we published on this in 2021, was giving men with metastatic prostate cancer testosterone. And those men came to me from all over the United States, pleading with me to be able to do something, with the argument that, "Doctor, I know I'm going to die of prostate cancer, but while I'm alive, I'd like to live as well as I can, and I'm willing to take the risks." And those men I told, "Listen," especially early on, I said, the training is that the testosterone could kill you within days or weeks. And they would say, "I'm willing to take that risk because what I'm living now isn't a life."
Well, you faced a big uphill battle to convince the medical world that testosterone was safely used, could be safely used. Share with us that uphill battle and the heat that you took from delivering at AUA, where luminaries stood up. And I don't know exactly the words, but they insinuated that you were a charlatan and a fake. And how did you overcome that?
There have been a couple of really challenging moments. I've given lectures where people walked out. They said, this is absurd. This is dangerous, what you're saying. And the thing that gave me courage, if you will, or confidence that what I was doing was okay, was simply the patients. and what we observed in these men. And the truth is that if by accident or whatever, there was very little testosterone that was given to men in the 1980s when I finished my training and started practicing, and in the 1990s. The belief that testosterone caused prostate cancer and it was really dangerous was one of the foundational concepts in urology. And just by offering it to a reasonable number of men and being able to follow them and report on their results, by itself actually broke new ground. The endocrinologists were giving it to very, very small numbers of men who had pituitary tumors or hypothalamic issues, and some men with genetic issues like bad Klinefelters with very low T. But that was it. And they usually stopped when those men hit their 40s or 50s because they were worried about prostate cancer. So I knew what the data was showing. And I also knew as time went on that the basis for the belief in testosterone, I mean, I had to go to the library for this. The basis for the belief that testosterone was dangerous was built on almost nothing. And one of the most climactic days for me in my life, one of these moments where you'll never forget it, is I was already on the lecture circuit talking about my experience with testosterone, and Paul Lank, who was one of the great prostate cancer specialists of the time, came up to me afterwards, and he was considerably senior to me and said, Abe, that's very interesting stuff, but you know, it may be different in metastatic prostate cancer, and Charles Huggins showed that it was, and you should probably be careful. And so I went to the only way you could get articles back then, old articles, was you had to go to this strange building that the younger people don't know much about. It's called a library. And to get the old articles, now you can get everything online. But I remember going down to the basement of the Harvard Medical School library, Cantway, it's called, and finding the original article by Charles Huggins from 1941 and reading it. And I was terrified as I read it, because Charles Huggins is sort of the patron saint of urology. And the final sentence of his landmark article was, testosterone injections activate prostate cancer. Testosterone injections activate prostate cancer. And he wrote that it was his first article where he castrated men and, you know, with metastatic cancer, and showed that acid phosphatase got better. And he also wrote that giving testosterone to these men in every case raised their acid phosphatase. And I had visions of the Harvard police or the local police coming into the library and taking me away in handcuffs for having put all my patients at risk who were on testosterone. Not that I'd seen it, but Huggins was saying it, and I forced myself. It was one of those feelings, you know, in surgery, sometimes things aren't going so well, and maybe you're feeling like you're in the middle of a bad complication. There's this tightness and sweating, and the acid comes up. And I had that moment. And I forced myself to reread the article and said, I just asked a few questions to myself. How many men did he treat with testosterone? The answer was 3. Of those 3, and how long did they get it for? 2 weeks. Of the 3 men, he only gave results for 2 men. Of the 2 men, one of them had already been castrated, which today we understand is a special case of being androgen deprived. In the end, this conclusion that that Huggins made, testosterone activates prostate cancer, was based on 1 man who received testosterone for only 2 weeks, and his acid phosphatase curve went up and down and up and down. It was impossible to draw any conclusions from that curve. And I knew that was the basis. And so even though there was resistance to what I was doing, you know, what happened is that some people were encouraged and started doing some of the same work. And as more literature came in behind me and more people became accepting, it was easier to move forward.
Well, that's a very interesting backstory on how this all evolved. Could you, I think this is a nice segue into your saturation theory, which I think you are so well known for, and which has really changed the course of thinking as you have the data to prove it. But could you explain your saturation theory?
Sure. So we have this paradox, right, which is that we treat men with androgen deprivation if they have advanced and especially metastatic prostate cancer. And you can see the PSA. I mean, every urologist has this experience. PSA drops like crazy. Plenty of evidence that if you have masses, they often shrink. And yet, there was paper after paper after paper that showed that number one is that prostate size with BPH, for example, which is all, and benign prostate acts the same as prostate cancer with response to androgens, is that BPH was unrelated to testosterone levels. PSA was unrelated to testosterone levels. Volume was unrelated. And there were studies where supraphysiologic doses of testosterone for periods of up to 6 and 9 months didn't change the PSA. So the paradox is, how can lowering testosterone lower PSA as an example of, as a surrogate for prostate or prostate size or prostate cancer, yet raising it didn't seem to do anything? That's a paradox. And so I went to the literature, we pulled together all the information we could find from animal cell cultures with, you know, LINCAP cells and other prostate cancer cell lines, and humans. And it became clear that there's a point that clearly prostate cancer cells need a certain amount of androgens or testosterone. DHT, in fact, is even more potent. But at a certain level, the cell cannot use any more androgen to do anything additional. And that point happens at a pretty low concentration, on average, somewhere around 240 to 250 nanograms per deciliter. And the proof of it is that you can take a man who comes in with very low testosterone, and if you give him testosterone, his PSA will almost certainly rise. If he's below that saturation point of 240, 250, his PSA will rise. But it doesn't keep rising over time. It becomes a new baseline. And he can be, and we've shown this over and over, he can be on testosterone for years. His PSA will be at whatever that new PSA is. All of which makes sense, because PSA is a chemical that is androgen dependent. So if you take healthy volunteers and you give them a form of ADT, an injection of something like Lupron, their PSA will go down close to zero. As the testosterone rises, their PSA rises, but it comes back to where it was. And so saturation is basically acknowledging, on the one, it explains everything. It explains why androgen deprivation causes a lowering of PSA and a regression of some of the cancer mass, and also why, once you have an adequate level of testosterone, on average 250 nanograms per deciliter, raising it higher doesn't seem to change anything. And the evidence now in terms of prostate cancer is, you know, there's a lot of observational data, less in the way of randomized controlled trials, but the observational data is clear, is that testosterone, men who receive testosterone are at no greater risk of developing prostate cancer than men who never receive testosterone. In fact, there's some data they actually may have a lower risk, and that bad outcomes in terms of advanced disease in men who have a history of prostate cancer, it looks like it's no greater either. So there's a limit to how much androgen actually can stimulate prostate cancer. It's there, but it's only at the very lowest range of testosterone levels.
You have verbalized that very well, and I'm quite familiar with your saturation theory, and I'd like to include in our notes following the interview a reference so people can actually see the graph of what you're talking about. I think that would be very helpful for those who are not familiar with the saturation theory. Two more questions. One is, what do you see as the future of testosterone?
Thank you for that question. And I'll there is something that potentially is amazing for men, frankly, for women too, who also can have testosterone deficiency, have been shown to have benefits from it. And I would say on a grander level, I hope this doesn't sound overly grand. I think there's something that could be really good for the health of our society and for our culture overall. And the reason I say that is that the evidence at this point is simply overwhelming. That testosterone deficiency is associated with some of the most important healthcare conditions that affect us: diabetes, obesity, osteoporosis, anemia. There's evidence it may be related to dementia, low testosterone. And testosterone therapy has the ability to not only make people feel more alive, cognitively sharp. I mean, this is what we hear from our patients, right? And sexual too, but their health is better. And the data on this at this point are impossible to ignore, although mainstream medicine is doing its best to ignore it. And I think that we're going to be seeing I think there's been so much of a stigma around the word testosterone that it's really impeded our ability to embrace the value of testosterone therapy in medicine in general. You know, just as an example, diabetes. It must be number one or number two in our healthcare costs in this country and throughout much of the Western world. A beautiful randomized study done in Australia at multi-centers, 2 years, which is a long time, 1,000 people enrolled, big study, all in people with abnormal blood sugar glucose. And actually, to be included, you have to have an abnormal response to glucose load. And everybody had to do WW, what used to be called Weight Watchers. So they had exercise and diet as part of their thing. And one group, in addition to that, got testosterone. The other group did not. At the end of 2 years, the number of individuals with true diabetes by biochemical parameters was 21% in the group that did not receive testosterone, and 12%, nearly half, in the group that got testosterone. And a whole variety of other parameters were improved as well. And there was a large number of men who got testosterone who had started with diabetes who no longer had it. Their diabetes was cured with testosterone therapy. And yet we have a resistance to this amongst the American Diabetes Association and other groups. And part of it is that everybody thinks they know what testosterone is. You know, if this was a new molecule that came out with some crazy new name that was appealing, and we showed what some of the documented benefits are of testosterone, people would say, oh my God, this is the best thing. Everybody needs to be on it. You know, like the enthusiasm around statins when they first came out, for example. And yet we don't see that happening. And it doesn't happen because people think either it causes still prostate cancer, or there was a story that turned out to be false around the risks of heart disease, or they think it's all about sex, or it's because they think testosterone is fringe medicine that's practiced by these people on the outskirts of town who aren't really great doctors. That's the reputational part, or it's too good to be true. And we have to get past that, because we have evidence now, important evidence, that not only do men feel better, more productive, engaged in life, but also it's actually good for health.
Well, I genuinely hope that I can live long enough to see that our society and our culture gets that injection of testosterone that you're talking about. I think we're on the cusp of making that happen. Okay, Abe, I'd like to ask you last question. I know you're a writer. I've read several of your books. You and I have collaborated on articles together. Tell us about your recent book.
Well, my last book was called, it started out with being called Why Men Fake It. And it was stories from my practice that I thought told some interesting stories about how our bodies work sexually, and also with regards to testosterone. And I've got some, I described my experience and my journey with testosterone in that book. The title has now been changed, and it's what is the name now? Well, I'm blanking on it. I'm going to have to get that back for you. But if you look up why men fake it, and the key story was actually a young man who came to see me who was faking his orgasms, which at the time was something I had never heard of. Of course, we'd heard about women who fake it, and the psychology of men was something that has always interested me also. And I thought that was such an amazing story, and what it told us about men and how their minds work, that that is contrary to the, let's say, the reputation that men have. I think that on the whole, men are trying to do good. That's really what I think. On the whole, there always are exceptions. And yet often how we do it is different than what may be. Sometimes we're not so good at it, but the intentions behind it I see as men really trying to do a good job for their partners.
Well, Abe, you not only have done good, you've done well, and you are really just the best. Thank you so much for this interview. I've learned a lot, and I know the viewers will really appreciate listening to this video. Thank you again, Abe.
Thank you, Neil. Great being with you.